业协会会长赵启明教授上台，有请北京中日友好医院高占威教授上台，有请韩国欧二柔医院郑载任教授上台。好，请以上专家领导上台接受授牌仪式。接下来，让我们掌声有请美国顺科全球营销副总裁 Andrew Rose 先生以及医学博士 Gregory L. Ruff 为他们授牌。合影留念。好，请各位领导、专家入座休息。
Arose and then how I'm employing it today. I'm from the Triangle area of North Carolina. I taught at Duke for 16 years as a craniofacial surgeon, and then in the past 16 years I've just done cosmetic surgery. I use quills all the time. I have no financial interest in this anymore. So I have no disclosures. The day I came up with this idea was October 5th, 1991. I was thinking about how we close a wound surgically by tying a loop and knotting that loop. And a phrase that resonates today to young surgeons is to approximate the tissues, don't strangulate the tissues. But many times, the tissue inside a loop is strangulated, especially as swelling causes the blood vessels to be squeezed, and often the most common, in fact, reason for wound dehiscence is ischemic necrosis of the wound margins because of sutures. So I was thinking about these knots and these loops, and I grew up in southern Michigan. I've always been interested in animals. I was a Boy Scout and then a zoology major at the University of Michigan. And I was thinking about porcupines, trying to avoid the problems with tying these knots. A porcupine is an animal that has modified hairs. These are made of keratin, just like the hairs on our head. And very much like the hairs on our head, there are little scales or barbs on the sutures. Looking back, if I had had any sense as a marketing person, I would not have called them barbs, because many people who come to my office are afraid of barbed wire. I would have called them ruffles. In any case, the idea of having the barbs go into the tissue and not be able to be backed out struck me as a nice way to avoid this compromise of the blood vessels. And the aha moment was to put barbs in two directions, as you see in the diagram below. A couple points to be made there. One is the red line is what we call the transition point. One of the axioms of barbed sutures, or the bidirectionally barbed, is that the tissues always gather at that transition point. And the day I thought of this, I realized if I can shift tissues along the axis of that suture, I can do lifts. I could lift the face or the breast. And so it had both a cosmetic aspect as well as a wound closure aspect. The other thing about having barbs in two directions is that surgeons, unless you're ambidextrous, have a problem often sewing backhand. So near the end of this talk, when I show you the closure of an abdominoplasty, I will talk about ways to avoid sewing a bidirectional suture backhanded. I came up with this idea in October, and about 5 months later, I made the first barbed suture. This is a picture of my wife, who's with me today. But I have a ruler, a scalpel, and a piece of weed whacker cord. I'm going to cut the barbs in this cord. If we can get the video to play, do I need to press something to facilitate that? It's a very brief picture of me cutting the barbs in this piece of weed whacker cord. We just try going forward, see if that activates it. I cut the barbs in a way that seemed to make sense to me geometrically, instinctively. I cut the barbs at about a 30-degree angle, about a third of the way through the weed whacker cord, and in a way that plants maximally absorb light along the stem. There's a helical array to increase the light absorption by the leaves of the plant, and I thought the same thing would probably pertain to a barbed suture. Subsequent research proved this to be true. So I took my piece of weed whacker cord and stuck it into a piece of steak and tried to pull it out. And I realized this really has some potential. So I began cutting barbs one by one on ethicon sutures to do operations I was already planning to do the conventional way. If we can't get the video to play, we'll just continue then. As I use these in my reconstructive cases, oh, here we go. So this is, I think, February of 1992. I'm taping the suture to a ruler, and I'm cutting the barbs. Our firstborn son was asleep. It was about 2 in the morning. There was finally peace in the house. So there's just a little documentary of our first barb suture. At Duke University, I had to tell the powers that be that I had a device that was patentable, and they granted me ownership of it because it was just an idea. And so I went to the attorneys in town to do patent work, and I got 2 patents, one for a barbed suture that had sufficiently sharp ends, i.e. needles, to penetrate tissue, and the other one was an inserting device for barbed suture. And I'll show you a picture in a minute, one of my first patients, where I used both of these techniques to help support a repair of her lower eyelid. Interestingly, several years later, one of the more famous, much more famous than I, plastic surgeon named Dr. Harry Bunke, came up with a similar idea. In fact, after we started our company, quill, we found somebody who back in the 1960s had a similar idea. He was an orthopedic surgeon, and he was trying to repair tendons using barbed sutures. He had a couple problems. One is a tendon needs to be wrapped with a barbed suture. He was putting his straight up there. Furthermore, his suture had teeth on it, as he described it, like a saw. But one of the scary moments in our adventure was when we found this patent that was only available in England, and this article that had been written in the Journal of Bone and Joint Surgery describing his device. So I wasn't the first person to conceive of barbs in two directions, but probably the first one to employ it successfully. So going from handheld sutures and cutting one at a time, I found a partner. His name is Matt Magaro. Matt and I came together and formed quill Medical in 1999. The first device we used was this vise that had a shelf in it. The suture was put down in the vise, and it didn't go all the way down. And we used an array of blades to slice the barbs in two directions. And then later we developed the machine you see in the middle slide, and that's when we started commercializing this with surgical specialties. And the first product that was approved, or cleared I should say, by the FDA was the so-called contour thread, a size 2-0 polypropylene suture. And that was the machine they were cut on. Later on, instead of cutting multiple barbs at a time, there was a capstan and one barb was cut at a time. And I'm not sure what the state of the art is today in Tijuana, but suffice it to say, it's much better than the original ones that are cut by hand. Through the tissue with the needle, the barbs I cut in the reverse direction, I used an IV catheter to introduce the barbs. And then I pulled up on those sutures just like you lift a hammock off the ground by pulling on the ends to help support that eyelid repair, which is very delicate and prone to relapse. So, as I said, the contour thread was the first device made. It's no longer in production, nor is the articulus, which was the second generation that replicated the barbs in two directions, hence has needles in two directions. But these were exciting to me because you could lift the face without making incisions. And I think going forward, I hope that surgical specialties will reinvigorate the research into this and exploit its promise. So, in summary, you've got no knots. One of the things that I want to make sure the audience understands is you see times that the advertising or even the literature about barbed sutures talks about the tension being equal. The tension is not equal along a barbed suture. And in fact, that's one of the virtues of a barbed suture. Imagine you are closing a wound and you start in the middle of the wound and you go in each direction with each end of the suture. What that does is it prevents the suture from moving back toward the middle of the wound. A conventional smooth suture will move. The tension will be greatest in the middle of the wound, and that's where the suture will move and allow that wound to spread. Just like when you go skating, you tie your skates up. When you get off the rink, the places are always very wide where the tension was greatest. That will not happen with the barbed suture, so it has the security of an interrupted closure, but the speed of a running suture. The other thing I like about it is the fact that the surgeon has control. When I pull a conventional suture through tissue, I need to hand it to an assistant so I can reload my needle with a needle holder. With a barbed suture, I pull it as tight as I like, and I know it's going to stay right there. So control, speed, security, and it's a lot of fun. Now, there's variation on the theme. Of course, there's a unidirectional suture. Surgeons were all taught to sew from the far end of the wound toward us, and then you can sew forehand the entire distance. So there's certainly room in the surgeon's armamentarium for a unidirectional suture. The nice attribute of the quill in a unidirectional fashion is that the loop is variable. The Quillidian product, the V-lock suture, only has the small loop. This one has already been laced through that loop. and it gives you a much bigger target and makes it much faster when you're closing a wound rather than trying to find that little loop with your needle. So one of the huge advances in surgery that started in the 1970s was making absorbable polymers that match the wound healing rate. So there are two absorbable sutures that are barbed today. Monoderm, which has a half-life of about 12 or 13 days in terms of its strength, and polydioxanone, or PDO, that has a half-life of about 5 weeks. We found at quill virtually any monofilament could be barbed. Obviously, a suture like quill, which is braided, cannot be successfully barbed. And then there are polypropylene sutures for those areas where you need a permanent suture. I have a hard time envisioning a conventional suture that can't be replaced by a barbed suture. So the only conventional sutures I tend to use are for tacking a wound just to get it lined up, and everything else I do with barbed sutures. When we started quill, we cut our barbs to a certain depth, and that's what led to this recommendation that you use a larger size quill than the conventional suture, because we were measuring the strength of the suture. I'd like to see as research moves forward and the barbs are developed and refined for different tissues, hopefully this somewhat confusing transition or equivalency could be eliminated. But in any case today, if you use a quill, use a one size larger than the suture you usually use. So the first study we did at Duke University, and the FDA insisted this be a wound closure that wasn't a very risky one. So we closed C-section wounds in the deep dermal layer. We compared the quill, made a PDO, to the same substance, the PDS suture of Ethicon. And because this was an equivalency trial for what's called a 510K in America, we wanted to show that it behaved the same. It did behave the same, except for one thing. If you put a knot in the deep dermis, it will spit through the skin 4 times more often than a barbed end of the suture. So when I was discussing this with the surgeon on the FDA panel, I said, plastic surgeons, in fact, most surgeons, tend to use PDO for deep dermal closure because of this propensity of the knots to spit through the skin. But having done this now, I've also found out that the longer a suture lasts, the better the scarring is. If you can bring the wound edges together and hold them there, your scar will be narrower. So, everything else being equal, a permanent suture is pretty much equivalent to a PDO suture. A vital suture will leave you with a wider scar, and certainly if you use a monoderm in the skin without any reinforcement, your scar will be even wider. So I use PDO all the time. And again, I'll show you this with some clinical results later in the talk. But suffice it to say, there's been many, many papers on this now, and we do need to flesh this out, so to speak, with more research on lifting the skin without incisions. So, some of the research we did at quill needs to be continued today. Here's an example where we changed both the cut depth and the cut angle. The deepest part of the suture is going to determine the breaking strength of the suture. But you see in this graph that going from design A, the orange, to design B, we increased both the holding strength and the tensile strength. So it was a win-win situation. And this varies according to tissue. Dr. Martin King at North Carolina State University and his cohorts, one of whom is in the back of the room, Wei Kong, who just got a PhD in Raleigh, North Carolina, have pursued this research. And his lab came up with a difference in the holding strength in different tissues. someday there may be sutures for each type of tissue that we engage. Also, going back to the helix I talked about originally, the greater the helix, the better the holding strength. And you can see the first one is a very loose helix, and the second one is a very tight helix, and that's what that same orange type A or model A barb I showed you in the previous slide. Having more barbs helps. You can see the third one compared to the first one. They're both a lazy helix, but more barbs is helpful. And finally, that second model shows the superior holding strength, or in this case, twisted pull-out strength. Again, slightly better with more twists. So these are ways of optimizing performance that continue to need to be explored. This caused a lot of trouble. We found both in rat skin and in this fake chamois that's sold by Turtle Wax that buff your car, that using a very fat needle in relationship to the diameter of the thread reduces the holding strength dramatically. However, I've used many different types of needles on these threads, and the problem is this has not been tested in living animals. This was time zero on the benchtop, and I think that the type of needle is probably much less important than the data shows. But the reason that quills had a lot of tapered needles and slender needles was because of this research. I'd like to see the study done on living animals, and I don't think the same profound difference would be true. This is probably the most important thing to optimize the holding strength of the suture. On the left side, I put a suture in straight. These were done with human cadavers. And on the right side, I made a J-type curve on the end of the suture. And you can see the profound difference in the holding or pull-out strength. This is fortunate, obviously, because as surgeons, we use curved needles all the time. So the more curve you get, the better the holding strength. One way I like to envision this, if you're looking along a straight suture, and these barbs are engaging collagen fibers, when you pull on the suture, if you start tearing the collagen fibers, the next barb coming toward that area won't have anything to grab. But if it's on a curve, there's always some new fibers on the inside of the curve. So when you're sewing things up, the more curvature, the better. And germane to people who do cosmetic surgery, and this goes back to the business with the needles. If a big needle causes a lot of trauma and make the holding strength worse, what would happen if you did liposuction? And this was done on the back of a cadaver, and in fact, there's very little reduction in the holding strength, even after thoroughly liposuctioning the fat from the tissue, because you're leaving behind those collagen fibers. Here was a study we did at the University of Virginia showing basically that the Johnson & Johnson or Ethicon product over 4 weeks in rats and over 6 weeks in pigs behaves the same. So the wound holding strength is equivalent to the conventional suture. This is just the trial we did at Duke I mentioned already. So suture lifts, what I'm referring to here is an incisionless lift, like the contour thread could achieve. This is one of my original patent drawings. I envision putting these sutures in opposite directions in a linear fashion where one end anchors the other end. But after doing that a little bit, I rapidly realized that if you make it in the shape of an upside down U, with a transition point at the bend in the U, that you can have all the barbs targeting the tissues, in this case the brow. You can see on the patient's right brow there, we lift that up. As long as the anchor is secure, you can utilize your suture more efficiently. It's important to make the distinction by the U and an upside down U. So on the left-hand side is a suture placed in a U, and you're trying to lift from the bottom of the page up. That is equivalent to using an ordinary suture. just like the Venetian blinds on your window. When you start to lift it up, it gathers at the bottom. When a woman comes in and says she wants her jowl lifted, she doesn't want it crammed up like this. If you put the suture in an upside down view, like on the right hand side, remember, tissue always gathers at the transition point. All that tissue is moved up. And when I lift a woman's jowl, it not only more dramatically lifts the jowl than a conventional suture, but it adds some height to the cheekbone, which is lost with aging. So these are slides we use to teach the contour threads courses, but these are vectors I use today. With the addition, over the past year or two, I've been moving this vector of lift even more vertically. And now I place, most times, instead of lifting the cheek or the jowl of the patient, I place the anchor way up high in the temple. And I not only can lift the cheek, but you're also lifting the lateral brow a little bit as well. So it can help with the curves. The needle is not placed in the skin. It's placed several millimeters beneath the skin, the deep subcutaneous fat. Again, you see the oscillation of the tip of the needle. That is germane to the theme I was talking about earlier. The more curvature you have, the better the holding strength. And in fact, you don't need to move the needle when you're working on an aged person's face. You can move the face as well. But you don't go superficial and deep. You don't want to show any rippling in the skin. You go back and forth, and you will not see the skin ripple. The suture emerges from the skin. You hold the ends, and you push the tissue up. And I push it up as high as it will go. We know there's going to be some relapse, as there is in any conventional lifting procedure, with or without an incision. So I push it up as high as the barbs will allow. The anchorage, we just mentioned the anchorage. In the temple, it's the fascia of the temporalis muscle, the so-called deep temporal fascia. It's very strong. In the neck, the anchorage is in the sternomastoid muscle. Again, the fascia is very strong. And I usually direct the suture one toward the area between the chin and the cervical mental junction, and the other one roughly at the cervical mental junction. With the brow, the anchorage is in the galea, the tendon between the frontalis muscle and the occipitalis muscle. And I will look in the mirror with the patient, have the patient look in the mirror, and decide where I want the arch of the brow to be. And I will straddle that. If they're too far apart, the brow looks flat. If they're too close together, the brow will be too peaked. I'll mark that in advance with the patient's approval. So here's a woman who had very heavy brows and also very strong frown lines. And I told her, she would benefit from a conventional lift, and she said, no, I want to spend my money in Europe, so I'd like to do this barbed suture I saw in the news. And so on the right-hand upper slide, you can see immediately after I've done this, and I pulled this at quite an angle, not just up, but out, to help that frown line. And then 6 months later, and 12 months later, you can see the result. So it's a modest result, but when I looked at patient satisfaction with these procedures, it was fairly consistent. It ranged between 75 and 80% of patients were happy with the outcome. When I said to the other 20 or 25%, are you ready for surgery now? Make an incision, remove some tissue? 4 out of 5 of them said no. I want to do those barbed sutures again. I'm hoping I can get just a little bit more out of them. So it's a very acceptable procedure to many, many patients. The ones who said, I'm ready for surgery, tend to be the older people with more skin laxity. This was about as good as I could do on the neck. This lady came to me and said, I don't like my neck. I said, I think you should have surgery and have a face and neck lift. And she said, I saw you on the news. I want to try the barbed suture. So in the middle picture, you can see the purple dots are where I was directing the suture in my local anesthetic. I showed her in the mirror. I said, look, I'm going to take the skin from the center of your neck and I'm going to push it back here. And she said, as long as it goes away. She lived a couple hours away, so I didn't want to make her drive excessively. I said, let's see you in 3 weeks. Keeping my fingers crossed that would be gone. And in fact, you can see 3 weeks later. Now, when you stretch skin, within 24 hours you can see it's growing. The DNA synthesis increases. Similarly, the skin that's reduced or made slack slows its growth rate down in a very similar time frame. Patients say, what happens to that skin? I say, have you had a baby? My wife's been pregnant 3 times, 4 babies. And it's amazing how fast slack tissue tightens up. And that's what happens to the redundant tissue you see. So, in the average patient, it will go away in about a week. There she is 6 months later. It's results like this that give me faith that these sutures have a lot of promise for lifting the face. And it hopefully will allow us to revive either the polypropylene suture or perhaps an even longer lasting poly that eventually absorbs. The other thing about the contour threads is they were $400 for that thread, the articulus, with barbs in both directions. That's a lot of money for one suture. I would have liked to use more sutures in the person's face, but there was the financial constraint, and the second thing is the fact that it was a permanent suture. And so I tended to use the patterns I showed you and no more. But there's room for putting more sutures in the face, particularly if we can come up with an absorbable version that lasts a long time. One of the things I encountered occasionally was a suture that showed when the patient animated their face. This was by far most common in the forehead. The forehead tissue is thin and being right on your frontal bone. When a patient raised his or her eyebrows, you might see it ripple under the skin. And I would say to the patient, if I take it out immediately, your brow will lift, it's going to fall. If I take it out in 6 months, it'll stay right where it is. So if we have a suture that lasts long enough, about 6 months, I think we could use an absorbable product possibly to achieve these lifts. And then the patient can keep coming back periodically with this very acceptable procedure and never have to have a scar or an incision. This is an 82-year-old woman who was a nurse. I said, you need a face and neck lift. She said, I saw these sutures. I put some acid on her face because her skin was like parchment. And I brought the sutures out near her mouth, and there's a second little bloody dot below that. But I was afraid that that skin was so thin it would show. And at 3 months, I said, I was hoping it wouldn't show. She said, what do you mean? I said, well, I showed her in the mirror. I said, you see in your cheek there, that little ridge? I said, do you want me to remove it? She says, heavens no, not if my lift will fall. And that was the last time I saw her. So she was very pleased with the cosmetic result. So I told you that we're not used to using PDO in the deep dermis. But as a result of our study at Duke, closing these C-section wounds in the deep dermis, I've arrived at this technique, and I use this all the time for breast closures, abdominoplasty closures, and so forth. And so my needle's inserted obliquely, a couple millimeters below the skin. I angle up to catch the dermis. It would create a dimple in the dermis. I like to say kiss the dermis, so I put some lips on the drawing. But when you come back into the wound at the same depth, what that does is it keeps the suture away from the cut edge of the wound, because it's a couple millimeters deep. It engages the dermis away from the edge, and so that dimple, which has some tension on it, and probably has some compromised blood flow, is surrounded by vascularized tissue. I'm not harming the edge of the wound where already the blood supply is the worst. What's more, when you pull this together, as you'll see in a minute, it everts the skin beautifully. So those edges are being compressed against one another, and that's what allows a wound to remain narrow, because it heals as that ridge is subsiding and the dimples are going away. The ridge always goes away, the dimples always go away in the 20,000 of these sutures I've used in my practice. This is a little video I'm going to show using a bidirectional suture, but just a couple shots if we can get that to work. So you put your needle in, trying to kiss the dermis, a little bit away there. In this case, I'm coming out a little higher because I'm trying to close some of the subcutaneous tissue as well. And I pulled it until the barbs in the reverse direction caught. So I know where the transition point is just by pulling gently. Take another bite, going in superficially, coming out deep. There. Now, I want a little tighter, pull it a little tighter, it stays right there. That's what I'm talking about, control, which is something most surgeons crave. So, when I started doing procedures where I made an incision and removed the skin that was made redundant by a closed procedure, my satisfaction rate went from 75 to 80% to over 92%. And so it involves surgery, it costs more money, it takes more time, but you have substantially higher number of happy patients. And again, I will use a third vector, a more vertical vector these days, starting up high in the temple. It's easy to undermine the scalp. And so you can lift not only the cheek up, but get the scalp out of the way. And you don't have to worry about increasing the crow's feet. Here, if a woman has a lot of laxity in her outer eye area, you might see the crow's feet increase, but if you put the suture up here and anchor it again in a deep temporal fashion, you can eliminate that, in fact, tighten the crow's feet up a little bit. This is a patient, she's under propofol anesthesia. What I've done is I've made an incision around her ear, and I've dissected the skin out to that dashed line, the outer line. And I'm comparing now a purse string suture. This is what surgeons conventionally use today. They put in a purse string suture requiring multiple bites in the subcutaneous tissue and the fascia beneath that, the so-called SMAS layer. And I want to compare it to a barb suture. You can see both are in place in each of these pictures. But in the upper right-hand side, I'm tying the purse string as tight as possible, and I'm raising the bottom of my dissection toward the ear, 8.5 millimeters. And I'm also, it's hard to see in this picture, but you're making a little ring that shows through the skin. And most surgeons will trim the fat a little bit, but also try and suture over that to flatten it. So it's time-consuming to put in a purse string suture. And like I showed you in the upside-down U versus the conventional U, it causes the bunching to be down low. I want all that tissue up. So if you use a purse string, and if you use a quill, and you pull on the tissues and push all of it up, you can raise it 10 millimeters. Better than a very tight purse string suture without the distortion and with a greater lift. So here's that patient before and after. So the procedure takes about, I numb the patients up myself, do them under local anesthesia, typically with some oral sedation, Valium and Xanax, and the whole thing takes me about 2 hours. Women sometimes request a breast lift, and what that generally involves is cutting out the skin above the nipple and the areola. And so that leaves a scar around the areola. Many times the scar will extend down vertically to the crease and even in the crease under the breast. So here, I'm anchoring the suture through 2 puncture wounds below the collarbone. The anchorage is the fascia of bending the needle in the shape of a J, and then I straighten it again. So now I have 2 threads, 2 long needles, and I go back in the same holes. And I wiggle back and forth, and I come out at the edge of the areola. Then I take my needles and bend them into a large curve. More curve, better holding strength. And I go back in that same hole again and come around underneath like a J. So this is a way to lift the breast without scarring. This was the first patient I did. And there's a couple lessons here. She had breasts of the same size, but you can see the left nipple is down and out. So there the threads are in place. I put in breast implants through the incisions in the bottom of the breast, these are mammary fold. Same size implants, same size breast to begin with, but the nipple disparity. Now, again, I've made some dimples, and I've tightened the thread up. I've lifted her a little bit higher. I wished I'd pulled her a little bit more toward the midline. But she said for 2 months, she knew that thread was still intact because when she would go downstairs and her breast moved, it would pull on her fascia. And I was thankful I only used PDO for this. Because if I had used a permanent suture, maybe that would have persisted forever. But she said in 2 months the suture broke. And when it broke, I'll show you the result in a moment. At that point, scar had formed around the implant. So things were pretty much stuck in place. I usually think that by 6 weeks, the scar is going to get stronger, but it's pretty secure, and patients can pretty much do whatever they want, even with a tummy tuck. So there's the intraoperative view, and there's the postoperative view. She's not fully corrected, but she's certainly much better using this internal type of lift with the PDO suture. Here's another woman. The scar that forms in this case is because I liposuctioned her breast. She had triple D breast. She wanted to be 2 cup sizes smaller, so I took out about 350 cc's of aspirate from each breast. So there's the view before tightening, after tightening. You can see the nipple being lifted, the breast being lifted, and the 2 shots in the lower quadrants. Here she is before. Notice where her elbow bends and where her nipple is. And look at how much her breast came up. I was afraid her nipples would point at the ground if I didn't put these sutures in. But with the sutures, I was able to rotate the nipple and the areola on the breast mount, give her a nice aesthetic result. Here's as Dr. McCarthy used to say, the asymmetrical cases are the toughest one. I took tissue out of both breasts with liposuction and was able, using the barb suture, to bring the nipples up, again, almost perfectly symmetrically. This is not a full abdominoplasty. This only goes up to the belly button. On the left-hand side, I'm sewing now with PDO suture. I use a number 2, and I start at the pubis. I'm standing on the patient's right side. And this is one of the ways to avoid sewing a bidirectional suture backhanded, a 2-layer closure. So I sew up the fascia. I use a running horizontal mattress. Again, more curvature. It shouldn't be a lazy sine wave type of suture. It's very much back and forth with a ratio of about 3 times the suture length to the wound length. So the first row of sutures tightens her fascia up, and the second needle goes over it and tightens it again. Both arms of the suture being sewn beforehand. On the right-hand side, there is a drain in this picture, but this is the technique to avoid drains, and I don't use drains anymore. I was just starting to do this then. The Pollocks, Harlan and Todd Pollock from Texas, plastic surgeons, have done 595 consecutive full abdominoplasties without any fluid collections and no drains. Patients hate drains. So what I'm going to use is an upside-down V, and I'm going to sew the fat to the muscle. And each time I do, I'm going to be pulling the fat and the skin with it a little closer to the bottom of the incision. And so on each side of the abdomen, I'm going to use one suture in this upside-down V, tacking it like the buttons on a Chesterfield sofa. And this will prevent serum from accumulating in the wound. Here I'm finishing that closure. You need to make sure you don't sew one entire side up because it'll be hard to see on the other side. What I'm not showing, I don't have a picture of it, but what I want to tell you about is when I'm closing the fat now, the layer of connective tissue in the abdomen is usually called scarpus fascia, and that's something that's important to close. It will increase your strength by about 50% as opposed to just closing the skin. So I use a bidirectional needle, bidirectional quill, and I start in the midline. Now, if you started in the midline and sewed forehand, the other end of the suture would theoretically be sewn backhand to make a perfect helix. But the small technical adjustment you need to make is you sew forehand with the first needle, and the second needle doesn't start on the other side of the wound, it starts right next to the first needle, and then you sew forehand toward yourself. So again, you can avoid sewing backhand with a bidirectional needle. You get those advantages of wound security that I talked about earlier. And then here's my closure that I showed you to kiss the dermis. There I'm several millimeters, 3 millimeters deep to the dermis. I'm arcing up to catch it, and I'm going to evert the wound, as you see here. I'm also, when I reach the end of the wound, I double back and do more curvature, a 180-degree turn, and I clip off the end flush with the wound. And there's the aversion. I warn patients in advance. It's going to look ridiculous. but that's going to keep your scar narrow, and that ridge will always go away. And then patients really love surgical glue, so I typically use glue at this point, but a lot of my colleagues would use a monoderm quill in the dermis itself, because it goes away quickly and you don't have any knots to worry about. But I have a penchant for glue. So, just one more technical point. And for this, I actually do use interrupted sutures. Those of you who do tummy tucks might like to try this for a belly button. I cut a U-shaped incision, I raise the flap, I defat the flap, I take a core of fat out, and then I fold the flap like that. So the upper part of the closure is hidden under the flap, which is a normal belly button anyway. So that's something you might like to try. In America, as we grow more and more obese, more and more of these procedures are being done. Especially, it's kind of ironic that bariatric surgery is being done with tiny incisions, and it's being done for patients who need huge incisions to reduce the excess skin that results from these bariatric procedures. And there's no better way to do this than with a quill suture. It will cut on my tummy tucks, pull down the plastic. That's about an hour and a half off the time it used to take me to do that. So I highly recommend it for these body contouring procedures. So I thank you for your attention, and it's a pleasure to talk to all of you.
感谢 Ralph 博士的精彩介绍。从他的分享中，我们进一步的了解了quill线及其临床应用。随着医美行业的日渐成熟，人们对美的追求越来越高，而医生在医美行业中起着至关重要的角色。净妍生物和美国顺科精心准备了针对线雕技术的教学平台快翎学院。接下来由净妍生物怡琳女士为大家介绍快翎学院，掌声有请。
尊敬的各位来宾、各位领导，大家上午好，我是净妍生物的怡琳。很高兴和各位相聚在上海，相聚在 Hyatt。首先非常感谢我们的快翎线发明者 Dr. La 对快翎产品精彩的介绍，强大的研发实力创造专业的产品，异动于行，快翎与时代同行。随着医美行业的日益成熟，人们对美的追求也越来越高，而这个时候，我认为医生在医美行业中起着至关重要的角色。近年来，抗衰新势力、线雕技术在呈爆发式的一个增长趋势，普及并推广规范、科学、安全的线雕美容技术，并给医美机构们提供专业化的咨询和治疗方案，一同推进、一同实现更安全、更有效的一个医美服务，是我们想做的。因此，我们希望成立第一个全球性的线雕学院，就是我们的快翎线雕学院。我们的初心，随着医美行业的日益成熟，线雕在医美领域中又被称为埋线美容技术。埋线是解决面部下垂和松弛最有效的方法。然而，目前很多医生都面临着如何使用埋线技术来提升面部的一个效果。那我们的快翎学院会提供全球交流学习平台，共同推进线雕的国际化交流，和行业的医生们一同推动线雕项目的一个长期发展。我们的组织快翎线雕学院是由美国顺科医疗器械有限公司和净妍生物技术有限公司共同成立的一个线雕交流学习平台。我们有全球顶级的技术顾问，通过技术顾问的一个教学， 我们会培养技术顾问的，通过全球顶级技术顾问的教学，我们会吸纳更多的行业精英们加入到我们的快翎学院中。另外，我们有在全国设立10大教学培训基地，启动5大公立医院和5大私立医院，更加系统化的开展医生和咨询的一个进阶培训。另外，更加注重医生的一个临床技术实操，更快速的启动优秀讲者的一个培训计划。我们希望让更多的行业精英们加入到我们快翎学院里，承担一定的行业责任，也承担一定的个人义务。第三，我们的服务人群主要是医美行业的医生、咨询、运营以及我们的消费者。我们希望可以通过快翎学院这个平台，让医生们可以更熟练地掌握线雕技术，让给运营们提供线雕项目运营的一个解决方案，同时给咨询提供线雕项目规范的一个咨询方法，一起来让线雕行业更加有序健康的发展。另外，我们希望也给消费者们提供专业的线雕项目的一个指导和建议。第四是我们的一个形式，快翎线雕学院会定期组织安排，分别针对医生、运营、咨询的一个线雕培训班、讲习班，还有一些学术专场会议，希望普及推广规范、科学、安全的一个线雕美容技术，给医美合作机构们提供更加专业化的咨询和治疗方案，然后一起来实现更加安全有效的一个医美服务。另外，我们快翎学院会每年在5月份定期组织我们的行业精英们去美国原厂交流学习，共同去参加一个国际间的一个学术交流活动。第五，我们的愿景，我们希望通过快翎学院这个平台，来搭建全球第一个线雕精准教学交流平台，普及推广科学的、规范的线雕美容技术，推动线雕项目的一个持续发展，为求美者提供优质的服务。以上是我对快翎学院的一个简单介绍，谢谢大家聆听。
感谢依琳女士的精彩介绍，相信在座的各位对快翎学院也一定有了浓厚的兴趣，想要加入快翎学院这个大家庭。下面将进行快翎学院的启动仪式，让我们掌声有请以下嘉宾上台。有请上海宋庆龄基金会怀训整形艺术公益基金主席、东方注射美容医学主编、上海交大附属第9人民医院崔海燕教授。台湾青年国际总店长陈俊光教授，浙江省整形美容行业协会会长赵启明教授，北京中日友好医院高占威教授，韩国 ORO 医院郑载润教授，医学博士 Gregory L. Ruff 先生，美国圣科全球营销副总裁 Andrew Rose 先生，圣科医疗中国地区总经理许树立先生，净妍生物技术有限公司总经理刘国田先生，请各位嘉宾一起上台完成快翎学院的启动仪式。 一起完成快翎学院的启动仪式。希望我们在未来的日子里共同努力，奋勇拼搏，开拓进取。我相信快翎学院一定会在大家的努力下越来越好。好，请各位领导先行就座。